Oh, okay.
Wonderful. Well, my name's Danielle Kenyon, and I'm very excited to have our 5th Pilot Grants Program awardees here to present for us here today. And it's my honor to introduce Dr. Soon-Hee Roh and Dr. Jared Geiger. Dr. Roh is an assistant professor at the University of South Dakota in social work. She received her doctoral degree from the New York University in 2010. She's gotten several grants, including this grant under KERCA. Dr. Roh has over 10 years of experience as a social work practitioner, and her areas of interest in research include positive adaptation in aging, health disparities, telemedicine intervention, and minority mental health and service utilization. She's been very busy and productive in writing manuscripts, with 10 published since 2014. Dr. Jared Geiger is also an assistant professor at the University of South Dakota in social work. He received his PhD from the University of Missouri School of Social Work in 2010. His research interests are in smart home technology for health sciences, remote patient monitoring, privacy issues, confidentiality, and acceptance of smart home technology. So as a co-PI, he was recently funded with a different pilot grant on older adults and visual impairment, enhancing daily behavior with tablet computers. So please join me in helping welcome Dr. Soon-Hee Roh.
Thank you so much, Dr. Kenyon. Good afternoon, everybody. I really appreciate Sanford Research Center and staffs for your generous and wonderful and unconditional support on my project. I'm very pleased and honored to present my research with my co-PI, Dr. Geiger, at the Sanford Research Center this afternoon. I would like to acknowledge first. As you know, this research was supported by the National Institute on Minority Health and Health Disparities of the National Institute of Health under award Dr. Amy Elliott. Originally, this study used a mixed method with a community-based participatory research approach. We recruited 5 community advisory board, and the community advisory boards mutually agreed upon primary responsibilities was to first identify project-related community needs and concerns. Secondly, they provide guidance on participant recruitment and dissemination, and they promote community support and involvement in this proposed research. Our team really appreciate 5 community board members: Lira Brokenneck, Sarah Brokenneck, Melissa Buffalo, Cassie Project, and Chelsea Westerner's great help on our research. Also, I would like to extend my acknowledgement to 3 external consultants: Dr. Daniel P. Wright, David Stocks, and Hyun Lee, on their advice, guidance, and recommendation on our project. The entire study was examined potential social determinant of the quality of cancer care and the quality of life among American Indian women with cancer residing in South Dakota. Our partner hospitals were Avera Medical Group, especially Cancer Institute, and Rapid City Regional Hospital, Cancer Institute, Sanford Research Center, and University of South Dakota. Today, Dr. Geiger and I will present our quantitative research result entitled Identifying Risk and Protective Factors related to depressive symptoms among Northern Plains American Indian women cancer survivors. In this presentation, we would like to talk about first brief background information, research purpose, conceptual framework, method, result, and findings, discussion, limitations, implications, and conclusions. Let's talk about first, who are American Indians? According to U.S. Census 2000 data indicates that there are 5.2 million American Indians and Alaskan Natives living in the U.S. Also, American Indians are a growing and heterogeneous population. According to U.S. Bureau of Indian Affairs, there are 566 federally recognized and 400 unrecognized tribes located across 35 states in U.S. Statistics report anywhere from 56% to 68% of American Indian populations are classified as urban. Where do they reside? States with the highest percentage of American Indians are Alaska, Oklahoma, New Mexico, South Dakota, and Montana. Also, there are certain states that have more than 100,000 American Indian residents are California, Oklahoma, Arizona, Texas, New Mexico, Washington, New York, North Carolina, Florida, Michigan, Oregon, Colorado, and Minnesota. Economics and poverty among American Indians. According to 2010 American Community Survey, about 30% of American Indian all families live below poverty line versus 19% of general populations. Approximately about 48% of American Indian single female head of household live below poverty level versus 41% for general population of single female head of household. About 16% of American Indians has unemployment issues in urban and 23% on reservation. As you know, American Indians has over 500 years of health disparities. American Indians have long experienced lower health statures when compared to other Americans. Also, many studies indicate that American Indians had lower life expectancy and higher disease burden exists. American Indians have a 10 years shorter life expectancy than general populations, and there are 10 leading causes of death. Number one reason is cancer. Cancer is the top cause of death among American Indian and Alaska Native women, and the second leading cause of death among their male counterpart. Second reason is heart disease. Third, unintentional injuries. Fourth, diabetics. Fifth, liver disease. Sixth is lower respiratory disease. Seventh, stroke. Eighth, suicide. Ninth, nephritis. And 10th are ranked influenza and pneumonia. I would like to talk about brief American Indians in South Dakota. About 9% are American Indian populations in South Dakota, and there are 9 reservations such as Pinelet, Rosebud, Roeboro, Cheyenne River, Standing Rock, Siston, Flandreau, Crow Creek, Yankton. Our partner hospital, Rapid City Regional Hospital, cover patients who came from usually Pinelet, Rosebud, Roeboro, Cheyenne River, and Standing Rock. East side of Avera McCarran Hospital covers patients who came from Yankton, Flandreau, Siston, Crow Creek, and sometimes Rosebud. I would like to talk about cancer disparities in South Dakota. According to a recent study, cancer mortality rate approximately 40% is higher than of the overall U.S. population in South Dakota. American Indians in western South Dakota present with more advanced stages of cancer than to non-American Indians in the region. According to Rapid City Regional Hospital tumor registry data, lung, breast, colorectal, and cervical cancer mortality rate was higher than non-American Indians in South Dakota. Particularly, American Indian women suffer from striking health disparities in relation to cervical cancer, including higher prevalence, lower survival rate, and rapidly increasing instances. This disparity can be attributed to multiple factors, including late-stage diagnosis, limited access to appropriate medical care, poor health literacy related to disease, trust issues, hopelessness, logistical problems such as transportation and finances. Purpose of the present study. The primary purpose of this study was to examine the relationships among adverse childhood experiences, perceived health, resilience, social support, and depressive symptoms among American Indian women cancer survivors in South Dakota. To achieve our research purpose, we made 2 research hypotheses. Research question number 1, what is the relationship between risk factors such as perceived health and adverse childhood experience and depressive symptoms among American Indian women cancer survivors? Research question number 2, what is the relationship between protective factors such as resilience and social support and depressive symptoms among American Indian women cancer survivors? There are 4 research hypotheses as they relate to female American Indian cancer survivors are as follows. Hypothesis 1, higher levels of adverse childhood experience will be positively associated with higher levels of depressive symptoms. Hypothesis 2, lower perceived health will be positively associated with higher levels of depressive symptoms. Hypothesis 3, higher perceived social support will be associated with lower depressive symptoms. Hypothesis 4, higher psychological resilience will be associated with lower depressive symptoms. To test our 4 hypotheses, we used resilience theory as a conceptual framework. Resilience is defined as an individual's ability to properly adapt to stress and adversity. Resilience is a 2-dimensional construct concerning both the exposure of adversity and the positive adjustment outcomes of that adversity. Despite 5 years health disparities, American Indians have demonstrated resilience in response to centuries of historical trauma, loss, oppression, and higher disease burden. Many research with American Indian populations, however, has focused on risk factors related to behavioral health problems. To offset this problem focus, resilience or positive adaptation in response to adversity is a useful theoretical framework. Adversities or challenging of life experiences are characterized by risk factors which increase the probability of negative outcomes. In contrast, protective factors are associated with positive life outcomes and buffer the impact of adversity. So, the current study examined depressive symptoms among American Indian women cancer survivors, introducing 2 significant factors, risk factors and protective factors. This figure displays our conceptual framework based on resilience theory. Our dependent variable is depressive symptoms, and we have independent variables, 3 socio-demographics: age, cancer diagnosis, time with cancer. Also, risk factors were adverse childhood experiences and perceived health statures. Lastly, protective factors were resilience and social support. Continuously, Dr. Geiger will talk about method, result, findings, limitations, implications, and conclusions of our study.
Thank you. And again, before I begin, I just want to thank Dr. Rowe for including me in the methodological piece of this project, and also want to thank Sanford Research Center and particularly the methodological core. That was been wonderful in terms of collaborating with us through this process. So the methodological approach we used to answer this research question was really grounded in community-based participatory research, and particularly Hacker talks specifically about the importance of community-based participatory research, particularly with hard-to-reach populations and populations that have oftentimes been historically discriminated against. And this methodology seemed like it was just an obvious approach with the population that we were working with. In order to achieve our goals, the main focus of CBPR was really working with the different community and community advisory boards and making sure it was clear to each of our partners and the subjects and the participants that we worked with that we weren't just interested in coming in, studying a problem, and leaving. We were really focused in creating a partnership, and a partnership that would ideally bridge academia, research centers, and the community as well. So we really worked with our partners and the community advisory boards and our participants. We made it very clear that we saw this approach as a bridge to get them engaged and continue they kept engaged, or would continue to be engaged from a sustainability standpoint. So. And our community advisory board and the members that Dr. Rowe talked about or discussed earlier were absolutely vital in this process. Throughout the whole assessment process and survey development, they provided very unique feedback, candid feedback in terms of what should be included, and really focused on the cultural appropriateness of the instruments that we were using as well, and focusing very specifically about the language and some of the cultural subtleties that perhaps, in my case, as a white male, that's even though I'm familiar with the cultural background, that there's still some subtleties that I would miss. And they were absolutely wonderful through that process. And again, I just want to acknowledge them again. We had 5 community advisory boards, 5 board members, and again, they worked with us throughout the process with our survey design. And again, we used a cross-sectional survey design approach. You may be asking yourself when I was introduced earlier with my background in technology and older adults, thinking, well, what does this have to do with this particular project? Well, with that background, I often work with very hard-to-reach populations and oftentimes small samples. And I try to use, and I use a lot of robust methodologies to kind of overcome small samples. So Dr. Rowe was excellent in terms of planning ahead and coming up with contingency plans when she was designing this study, and we were concerned about our ability to get an adequate sample size. So again, she was wonderful to include me in this process. So as you can see, we ended up recruiting 73 participants for this project. We did use non-probability sampling. We used primarily purposeful sampling and snowball sampling as well. And through that process, I don't know if Dr. Rowe, I suspect that she agrees, but I think the snowball sampling was a really unique piece. Chad, does this keep, it sounds like it cuts out periodically. Is it? Okay. Sorry about that. I'm just glad other people are hearing that, and it's not just me as well. Yeah. Okay, so we're getting back on to where we were going. So again, we use non-probability sampling, purposeful sampling, and snowball sampling as well. Eligibility criteria was 18 years of older, and again, Dr. Rowe spoke about our recruiting sites throughout the state as well. There were cash incentives that were included in this as well, and that's something that we have to consider in terms of, when we consider our findings as well at the very end. Also, there was a piece that I think was very well supported, and this was a wonderful idea that I believe came out of our advisory board, and Dr. Rowe was very open to this suggestion and really strongly recommended that this opportunity occur, that we looked at using additional incentives for gas support. That really seemed to help in our recruiting efforts as well, and again, it was just a nice token of appreciation. And again, had we not had that advisory board and that candid feedback, we may not have had the success, the preliminary success that we've had so far. Again, we talked a little bit about the theoretical or conceptual framework that we used. Our outcome variable or dependent variable, again, we were looking at depression. And specifically, we were using the Center for Epidemiological Studies Depression, CESD, short form. The variable was treated as a continuous variable. Our predictor variables, the risk factors, we used the ACE scale, and we also asked a single item that asked about perceived health status. So our other factors that we looked at were protective factors such as resiliency and social support. I apologize again. A couple things to keep in mind. Because of our sample size, it limited our ability to do at this time, to do more sophisticated analyses such as SEM. But I think in the future, the methodology and the preliminary findings that we found really lends itself very nicely to SEM models in the future. This slide here talks a little bit about and provides information about the samples, the reliability of the scales that we used, and gives a few sample items. The perceived health status, again, how would you rate your overall health on a 4-point Likert scale, 1 being poor health, 4 being excellent. Obviously, a higher score indicates higher perceived health. And the adverse childhood experiences, the ACE, again, higher scores indicate greater exposure to childhood maltreatment. The social support, it had 2 different dimensions or 2 different features to it, as you can see here. The first piece, the first dimension of the social support included the social support, which asked questions such as going to a doctor, preparing meals, helping with daily chores. I think of this in terms of activities of daily living or instrumental activities of daily living. And the second piece was the emotional support dimension that has 7 items, such as talking about problems, showing love, emotional support, so on and so forth. And again, a person that scored a higher score on the social support indicated greater levels of social support. Resiliency, the same thing. Higher levels of resiliency indicated greater levels of resiliency, or greater protective strategies, if you will. And the depressive scale, again, lower was better. Lower is the absence or suggested absence of depression. Okay. So I'm going to keep the results slide up here just for a moment, but before we actually, or while you're looking at those, I want to talk a little bit about the pre-screening that we did for the data analysis. Before we did our final, our hierarchical multiple regression, we did the data screening and tested all the major assumptions, and the data came back fine in terms of normality. So we didn't have any concerns in terms of using parametric statistics. Our KS statistic came back indicating that the data was approximately normally distributed. So with that, as you can see here, our average age was 57 years old or 56 years old. The range was quite broad, 32 years to about 77 years. Primarily, it's almost looks like 70% had greater than high school education general GED. The perceived health was actually quite high, 60%. Which is interesting, and there seems to be something going on there that perhaps maybe requires future analysis. There seems to be this disconnect in terms of perceived health and what the data is suggesting nationally throughout the states. And as you can see here, that's particularly the types of cancer. Primarily, 34% had breast cancer, and then cervical cancer was 28%. For the purposes of our analyses, we treated the type of cancer as a binary variable, since the original intent was to focus primarily on cervical cancer, but we ran into some recruitment issues with that. We ended up using just the mode. So since breast cancer was the most prominent cancer, we treated that as our 0, for lack of a better word, and treated all the other cancers as 1. There's certainly additional analyses that we could have. Thanks. Can you hear me now? Can you hear me now? Please, no one let me go to the restroom with this thing on as well. And I mean that not jokingly either. All right. Can you hear me now? Yes? Okay. So we treated the cancer variable as a binary variable, breast cancer, and then all other cancers as well. And again, you can see where our main areas of interest in terms of our predictor variables, the ACE, the average score was 2.5. Again, the range higher is more, more negative adverse events. Resiliency was 31. Again, this indicated a fairly high level of resiliency among our sample. And then our social support also indicated 37%, which was right about approximately in the middle. And then our depressive symptoms, which was really interesting, or at least from my perspective, what was really interesting is that there was a really high rate of probable depression, almost 50%. So that's something to keep in mind as we move forward and talk about future projects as well. Because of the sample size, and we were looking specifically at 7 different predictor variables, in order to make sure that we could reasonably come up with some really good findings and robust findings, we ended up using bootstrap resampling as well. And the reason for that is we achieved the 10 subjects per 1 predictor variable, 74 subjects, 7 predictor variables, but we wanted to really provide rich, robust parameter estimates for not only the communities that we worked with, but also the research community in general. So in order to achieve that, when we ran both the correlations, the bivariate correlations or inner correlations, and also the hierarchical regression, we instituted bootstrap resampling, where we used 10,000 resampling simulations, and then we did bias-corrected, accelerated bootstrap confidence intervals to provide even more precise standard errors and estimates. So when you're looking at this table here, you'll notice that you may not be able to see it here up on the projector, but there's parameter estimates that are in bold, and these actually indicate the statistically significant robust confidence intervals. So those are the bootstrap confidence intervals. The correlation coefficient that you see is actually the parametric coefficient estimate. So in this particular case, the correlation was 0.05, but the confidence interval was down here, the robust confidence interval. So as you can see that for our dependent variable or outcome variable depression, that's really the only thing that was statistically significant at the first level was perceived health. There was a negative correlation with that, and that was statistically significant at the parametric level and the robust method as well. For the ACE, resiliency, that was statistically significant at the parametric and also the bootstrap analysis as well, and the same thing for social support. Again, so it provides some interesting findings, and we'll talk a little bit more specifically as it relates to the ACE, because that's an interesting finding that was somewhat contradictory with what we would see in the literature, that there is typically a relationship between ACE scores and depression. But for this particular sample, and again, albeit it was a good size, adequate size for a pilot, we did end up instituting 10,000 resamples, so it ended up being a theoretical, fairly large sample, and we still didn't see anything. The needle wasn't moved in that aspect, so that's interesting, and I'm not sure what to make of that. So, for our main analysis, then we ended up doing again a hierarchical multiple regression. We had 3 steps. We first entered in our socio-demographic variables, or we could call those our control variables, and we looked at the specific increase in R-squared after each of these steps. As you can see here, that our control variables are step 1, age, cancer diagnosis, and length of time with cancer. None of the predictors were statistically significant. The R-squared was 6%, but none of the predictors were statistically significant. For step 2, we added the ACE and perceived health to the model, and as you can see, perceived health is statistically significant, and here again you can see the bias-corrected parameter estimates, and I think these are going to be really important moving forward, not only for our research team but other researchers as well, is that it's providing some parameter estimates that could be used in more sophisticated analyses such as Bayesian, where you could enter this information as priors. So I think that's really important, a methodological piece of this project as well. That's the coefficient was statistic, and it was statistic at a fairly large level. At stage 2 or step 2, we added resiliency and social support. As you can see, these are our protective strategies. Again, you'll see statistically significant findings here, and these are our parameter estimates. So at the end of the day, our full model of 7 predictors ended up predicting about 53% of the variance in depression, over half of the variance in our outcome variable. So we were really quite happy with that. So what did we find? Well, some risk factors, how a person perceives their health is important. Protective factors, resiliency, and social support are really important. And I think, and I'll talk about this in a few slides, I think it's really important to keep in mind that these are potentially some really, potentially impactful findings in the sense that we can work with and continue collaborating with and continuing partnering with American Indian communities. And these risk factors and protective factors are potentially modifiable. So we can work with individuals to see and understand the importance of to what extent and how they see their perceived health and what that can or cannot do as it relates to depression and mental health. And the same thing for protective factors as well. As social workers, if we're working with community providers, it's really important that assessment for how resilient a person is, to the extent that American Indian women, to the extent that they have a strong or a weak support system. That's very vital moving forward, because if we are able to tease out that American Indian women have low resiliency and have low social support, again, that lends itself very nicely to different intervention projects where you can look at buffering or enhancing resiliency and social support, and also addressing some of this perceived health-related issues as well. So again, this is consistent with this growing body of literature that's talking about this negative or inverse relationship between resiliency, social supports, and depressive symptoms. So we're finding some interesting results that are consistent with the current literature as well. Another piece that lends itself very nicely to intervention is this idea of there seem to be high levels of depression. Now, certainly the depression instrument doesn't indicate a diagnosis, but it can suggest that there are depressive symptoms. And again, we're looking at approximately half of the sample that was having some depressive symptoms. So in terms of working with individuals that have cancer, or American Indian women with cancer, not only is it going to be important based on our preliminary findings to not only screen for how they perceive their health in general, but also their social supports and resiliency. And more importantly, are they aware of depressive symptoms? Are they aware that this can and perhaps is more likely to occur in American Indian women with cancer as well? Again, future research obviously is going to have to confirm these findings as well, but that's a really interesting finding. And obviously, when you're working with individuals with cancer, that's rightfully so, most likely the most pressing issue that they're facing. But it's still really important to not overlook the importance of some of these psychological and mental health issues that are often accompanying the women as well. So what did we do in terms of rejecting or failing to reject our hypotheses? We failed to reject our first hypotheses, which Dr. Rowe talked about earlier. We anticipated, based on the literature, that there would be a relationship between the ACE and high levels of depressive symptoms, and we didn't see that at all. Again, the coefficient was 0.05, and even when we simulated the data, it didn't move the needle at all. So that's interesting, and this is contrary to quite a bit of the literature that's out there. So this is going to require our team and our collaborators to think more about what this means, and are there some unique instances or unique situations or factors that are specific to South Dakota as compared to some of the other states that Dr. Rowe talked about earlier. It will require some ongoing thought and discussion with our community partners. Our second hypothesis, we rejected. Again, we saw a relationship between perceived health and positive symptoms of depressive symptoms. Again, this is consistent with what we saw in the literature, that there's an association between how a person perceives their health and their depression, and intuitively it makes sense. If you think about the signs and symptoms of depression, it oftentimes impacts a person's mood, their concentration, their inability to think, and the more sedentary a person is, that could certainly increase or activate their depression as well, or depressive symptoms. We rejected hypotheses 3 and 4. Again, we saw a relationship between social supports and resiliency, and again, this is consistent with the existing literature as well. So we've added to our findings were consistent with, and we've added to the literature as well, which is nice as researchers. How are we doing on time now? As with all studies, this study has limitations. Again, it's a pilot study, and we also we ask that everyone take these into consideration when interpreting our findings. Again, we use the non-probability sampling, a purposeful snowball sampling as well specifically, so it limits the generalizability of our findings, albeit our findings with the bootstrap resampling, I think, are fairly robust. But again, the generalizability aspect of it, we have to be very mindful of that. It was a cross-sectional design, so in terms of causality, we have to be very careful about the arguments that we make in terms of that. It also lends itself very nicely, our findings, to provide additional resource that others can use as priors in future analyses as well. We didn't look at nesting tribal membership in our analyses. Data on tribal membership couldn't be examined. In the future, perhaps this is something that we should look at if there are contextual variables here that are going on. Are there differences in persons that live in one particular, that are affiliated with one particular tribe as compared to another? Again, this is something that we need to think about moving forward as researchers and as participants. Obviously, there's possible biases in data collection, although significant standards were taken in terms of training our collaborators in terms of how to deliver the methodology and how to deliver and collect the data, and we were able to train our partners on how to do their interviews and do the data collection. There still might be some biases that we're not aware of. We did have, we trained each of the groups that were meeting with our individuals out in West River. We piloted the project on each of them so they were sensitive to what we were looking at in our approach, and ultimately it helped us really reduce our amount of missing data as well. So that was a success. But outside of that, there may be some potential biases that we're not sensitive to. And also the measurements instruments that we used in general, albeit there were, although the reliabilities were really quite good, internal reliabilities in terms of the crown-back alphas, there needs to be additional research that looks at the validity with these instruments because they weren't designed specifically or weren't normed on American Indian population. So we have to keep that in the back of our mind as well. Implications, again, we need to look at the context, the person and environment, or an ecological perspective when we're working with American Indian women. With cancer, we need to think about and consider assimilation. We need to think about other things such as spiritual assessments. We're not reporting this today, but there was a mixed methodology component that there was a qualitative piece to the analyses as well that we're looking at a different time, but there was some preliminary themes that came up about the importance and power of religion and spirituality and how that could be a potentially protective factor as well, and we certainly need to look into that more. But that's a piece that should be considered as well when working with American Indian women with cancer. An obvious one when you start thinking about the protective strategies of social support and resiliency is looking at the importance of extended family, to making sure extended family members are all involved in the person's care to the extent that the patient wants them to be involved. And we also proffer some therapeutic services that should be considered or might be considered. Discussions with the American Indian woman in terms of issues related to stereotyping, justifying anger, positive identity development, and ceremony. So what are some of these contextual and culturally appropriate services that we can provide that perhaps might provide additional protective strategies or factors for us as well? And also the importance of discussing ritual and ceremonial practices. Again, that cultural competency piece I think is extraordinarily important here, and it could act as an enhancer for some of the supportive factors that we saw as well. So we're recommending, and our preliminary data suggests this holistic treatment approach where there's a systematic and an ingrained approach to care that looks at the physical, emotional, the spiritual, and the mental. And I think this is going to be very important. And our preliminary data suggests that this model perhaps might eventually be the standard of care moving forward if additional studies seem to confirm or suggest what we found. Some conclusions. I'll close with this. We have about 10 or so minutes for questions and answers, if that's okay. Our full regression model accounted for 50% of the variance in predicting depression. Again, there's certain limitations with that, but again, it's very promising. Perceived health, higher levels of resiliency, and greater levels of social support were significantly associated with lower depressive symptoms. So as we're working and continuing collaborations with the American Indian population, and we continue to work with them in disease management or health management, I think it's important to think about these factors are potentially modifiable. So again, it lends itself very nicely to educational campaigns, psychoeducational campaigns, skills training as it relates to resiliency and social support. And again, these are modifiable, whereas some of the other issues that you think about, or as a researcher you think about, well, what can I control? Well, we can't often control things such as physician access. We can't necessarily control for geographical, geography, for lack of a better word. But we can potentially control some of these other aspects. And again, I think it's important that we see them as modifiable as we move forward with our collaborations. The conceptual approach that was brought by Dr. Rowe, resiliency theory, seems well suited for this line of research, and it particularly relates to risk and protective strategies. So again, it lends itself very nicely to potentially modifiable behaviors and focusing on collaborating with our American Indian partners, looking specifically at resiliency and perhaps what that means to American Indians as well. And other recommendations just have to do with more pragmatic approaches in terms of improved screenings, looking at not only the state of cancer, but also looking at the depressive symptoms and whether they're subclinical or clinical symptoms as well. And what we saw here, again, from our Community Advisory Board was just a really wonderful collaboration and how vital that is to make sure that in our project that all of our interventions, all of our surveys, all of our communication was culturally sensitive. And moving forward, I think that's what I'm going to take with me is how powerful that relationship was, and how I think that our approach to cultural sensitivity and competence really helped us with our study as well. So thank you for your time. We're certainly open to any questions or comments that you may have as well. And I'll repeat the question so everyone hears it as well. I'll start off with that, and then I'll throw it to Dr. Rowe then as well. So the question was, and I'm paraphrasing here, is that with the community-based participatory project, kind of the classic research, well, so what? What are you doing with that now? You went in and collected this data. One of the things that we're doing is thinking about how to package this and disseminate this. So we're currently working on submitting the article for publication, but also with that going back then to the community and our advisory board and discussing the findings and getting their perspective on it. So we can say, okay, this is what the data says. Is this consistent with what you think is going on as well? Is there some consistency there? So in terms of specific things, we haven't scheduled those yet, but the intent is to go back into the community and talk about these findings, go back to the providers that we collaborated with and say, here's what we found. Keep this on your radar, for lack of a better word. Did that answer? Did that?
Yeah, additionally, we discuss about the psychoeducation issues, because it's a lot of patients talked about using a depression word they avoid. Usually they express anxiety and worry. So we would like to go, stop by at Rapid City Cancer Survivors Group meeting, and then we would like to educate to them what is the depression, and then what do we do prevent. So that's our now next process with the community advisory bodies, mainly focus on psychoeducation.
To follow up on that train of thought, from a social work perspective, what is a potentially modifiable factor? Which one would you most likely develop an intervention around? Would it be that internal sense of resilience, or more of that external seeking social support? Where would you see as most promising?
The question was, as social workers, what's kind of the next step? What do you see in terms of an intervention to these potential modifiable factors? I'll start off and then hand it to Dr. Rogan. From my perspective, I see it as what Dr. Rowe talked about before, is the psychoeducational component of kind of getting a baseline. Okay, where's a person's level of social support? If we go back to the model, you can see that's one of the most significant predictors in terms of beta weights. So to find out and identify, okay, where's the starting point? And if we can identify where a person's level is, come up with some type of customized treatment plan. If you're working on a one-to-one level, or working on for maybe more of a broader psychoeducational approach where you're delivering a psychoeducational training to a large group of individuals, how you could talk about these are the things that we need to look for. This is what we think resiliency is. How do you make sense of resiliency? Do you have another name for it? Should we think about something else? So I think that looking at whether it's maybe cognitive behavioral therapy type of interventions, that's looking at working with a person to think about how social support can cause improvements in health, how resiliency can potentially cause improvements in depressive symptoms. That's kind of where that jumped out at me, that there's this piece where you can come in and work with individuals, find out what their baseline is, and then say, okay, these are some things you can do to theoretically improve your situation, or decrease your depression, or keep it at bay, for lack of a better word.
He did perfect answer. Social workers.
How was the ACEs submitted or distributed? Was it in person, or was it? Okay.
Yeah, the question was, how was the ACE submitted, and was it for this one? Was it a paper based?
Yeah, we use 11 items, and the participant, circled yes or no questions, and the average score was most of the participants, have experience 2.5 over 3 child, maltreatment experiences.
What were you thinking from a methodological perspective? In terms of
you had said that hypothesis 1 there was no statistical or significance, and I was wondering if you ever measured it just to get to each question, where they answered positive on, when they answered 1 on the question.
We didn't do it for this analysis, but that's a good point. I mean, the whole idea of social desirability, if that's perhaps that's what's going on here, and that's something for us to consider as well from a methodological standpoint. That's a good point.
So how does the rate of depression compare to the population at large, both just the general community, not considered
Yes. So the question was, how does this population's rates of depression relate to the general population? I don't know if we addressed that in the literature specifically. I don't know if we addressed that at all. Well, I'll look in terms of, so this specific. Oh, so you mean as compared to non-American Indian? Yeah, okay. I see what you're saying. Yeah, we didn't look at that specifically, and I don't think we addressed that in our discussion section.
Yeah, we did a literature review, and we found some other countries. Iran, they did cancer patients' depressive symptoms. They report about 27% of patients indicated depressive symptoms through CSD. And also in American Indian older adults study I did, but at the time I used a geriatric depression scale. There is no depressive symptoms. And also another study from Dr. Agus Goins, they show some about 13% of depressive symptoms among American Indian older adults, not the cancer patients. There is no previous studies.
questions from the internet audience? We'll wrap up and thank you for your time.
Thank you.
Thank you so much.